Good afternoon, everyone. Today I'm going to speak on applied and clinical exercise physiology from basic research to therapeutic intervention, and it is the need of the present. I am Dr. Hanjabam Barun Sharma, and I am a medical and clinical physiologist as well as sports and exercise medicine doctor. Currently, the president of Indian Society of Sports and Exercise Medicine. So let's begin the talk. As you all know that the evolution of the human were in such a way that we evolve for the movement. We always, our ancestor, the Homo sapien was evolved in Africa as a persistent hunter, and that's why it has been said that the real reason for evolution of such an advanced human brain is to produce adaptable and complex movement. That's why being sedentary is against our evolution. So the enhance today the exercise in medicine as well as movement in medicine is coming up and should incorporate into it. Some says that we are not evolved to run, but we are evolved for prolonged walking also. So the difference of opinion is there, but one thing is very common that we have evolved for movement. Movement is in our evolution, and this was what you call a documentary on exercise and health science, which we met during I was there in AIMS New Delhi as a senior resident. So let's talk about the certain basic effects. The most important point about basic of exercise and the sports physiology is the grading of exercise. The grading of exercise is absolutely important. And before the grading of exercise, one must know the energetic of exercise, which energy supplies for how long. And depending upon that energy, the energetics involved, exercise can be divided into different types like aerobic exercise, anaerobic exercise, strength training, and all this type. And regarding the grading of exercise, which I met, by hand during my PG days, was based upon the ACMS guideline. Here it can be divided into aerobic as well as resistance training. And the aerobic can further be divided into different, component where intensity of exercise can be measured. For example, if we measure through percentage of ISR max, then very light exercise will be less than 57%. And if it is more than 57, equal to or more than 57%, but it is less than 64%, then it will be light exercise. And if it is equal to or more than 64%, but less than 76, it will be moderate exercise. So it is an easy way to remember it. 57, 64, 76, 96, 96. In this way, you will be able to prescribe the exercise to your patient or to the players. It can also be divided according to the percentage of HRR or heart rate reserve or VO2R or VO2 reserve, like 30, 40, 60, 90, 90. In the same way, percentage it can be divided as part of percentage of VO2 max, like 37, 45, 64, 91, and 91. Again, by using the MET, also metabolic equivalent of tax, where one MET is approximately 3.6 ml per kg per minute. It can be divided into 2, 3, 6, 8.8, 8.8. In the same way, rate of perceived action, which is more important for diabetes and all that, disease condition where autonomic dysregulation may be there. So rate of percent action can also be used for dividing the exercise grading like 9, 9 to 11, 12 to 13, 14 to 17, or equal to or more than 18. In the same way, resistance training can be divided into different intensity based upon 1 RM, one repetition maximum, one repetition maximum. How many repetition? Only one time. And it is maximum. That means a person is able to lift that particular intensity of weight or particular weight only once time by maintaining all the form. So that is 1 RM. That is, he or she is able to lift a particular weight by maintaining everything, every posture, every correct posture, only one time. So that will be one RM. So we fix that. We take it as a maximum, and based upon the percentage of the 1 RM, it can be divided into very light, like less than 30, it will be very light, and 30, 50, 70, 65, 65. Suppose if you don't have any kind of this instrument, then very roughly also, exercise moderate, mild, moderate, and vigorous or severe exercise can also be, prescribed roughly based upon what is known as the talk, talk test, where suppose if you are able to talk, if the exercise intensity is such that if you are able to talk but not able to sing and singing, then it will be moderate, intensity of exercise. And if you are not able to do both, like if you are not able to sing as well as if you are not able to talk, then it would be a vigorous intensity of exercise. So in that way, we can approximately, classify the exercise intensity also. Based upon the heart rate maximum, this is the approximate guideline where we can target a different, energetic, like ATP PCR or phosphagen system can be targeted, have a major role to play around 90 to 100% of HR max, that is exercise intensity. For anaerobic glycolytic system, it should be around 85 to 100%. For aerobic, it will be like 55 or 60 to 90% of HR max, or you can say 40, 50, or up to 85% of VO2 max. These are all approximate, and one must know that energy system is always overlapping to each other. There is no 100% that it will be only be done by aerobic system like that. So they are all mixed up. For details, one can read the sports physiology, which I have written, for EPG Pathshala. And it can be available both in YouTube as well as their website. Another important point, which is very important, is the how we are going to use the HR max, heart rate maximum. The most commonly used heart rate maximum is 220 minus, but unfortunately, this equation, it's not reliable, and this equation itself is not based upon any kind of the regression equation. It's kind of the assumption also. So there are different equation are available, more reliable equation are available for HRMX. One is like given by Tanaka, like 208 minus 0.7 into age in year. And the one basic formula which everyone should know is Carbonian method, which is applicable for moderate to high intensity of exercise, where we can convert the percentage of VO2 max approximately into training heart rate, or into the, uh, the the heart rate. Like example, if your this is your resting heart rate, then suppose you want to prescribe the exercise at a Z% of the VO2 max, then it will be then calculation can be done in this way, and where HR max minus HR raise is the your maximum your heart rate reserve. This is the maximum heart rate reserve. Like for example, if you want to do warm up, is basically done at 40 to 60% of the VO2 max for 10 to 20 minutes. 5-minute recovery should be given before your actual sports event. It may be using lightweight multi single joint exercise, and dynamic stretching may be done in case of the warm up. So this 40 to 60% of VO2 max you can convert into training heart rate zone. In the same way, for warm down also, after the exercise also, it's generally done up to 50% of the VO2 max for 5 to 10 minutes. Especially useful when your next pod is in 2 to 4 hours. So in this way, you can convert, practically speaking, you can, because VO2 percentage of VO2 max is not available to many uh, the coaches or the players or a normal people for that, but your heart rate monitor device can be, you can easily purchase from market. So by using this carbonate method and other similar method, you can convert approximately the percentage of VO2 max into your percentage of your heart rate, where you can actually do the exercise. Let's going to the next basic stuff is the physical fitness. One must know that physical fitness has so many components. It's like health component comprised of the cardiorespiratory endurance, body composition, muscle strength, endurance, and flexibility. So it is not only cardiorespiratory fitness. There are so many different parameters. Like for example, like body composition. In the same way, the fitness can also be skill based. Like these are very much important in case of the sports, and it can be divided into different components like agility, coordination, balance, power, reaction time, and speed. And I hope that I'm not going to detail of each and every one, because I hope that all these are basic, are being the foundation must be there. So these are the different sports, because being an exercise physiologist, being a sports and exercise medicine expert, you have to love your sport. So next, going to the next one, like let's speak something about a cardiorespiratory endurance. It can be done by field test commonly, or it can be done by ergometer based, like a treadmill test, SEPET, or the bicycle ergometer, or rowing ergometer, or different type of the ergometer which may be specific to that particular sports or exercise. And it can be simply measured by using different step tests, also like Hubbard step test, 3-minute step test, etc. There are so many tests. So by using this simple test, you can easily publish lots of paper, And by from the data collected, you can even predict, by using the different regression equation, you can predict the VO2 max also, using using easily measurable anthropometric parameters. And another, commonly used functional aerobic testing is a 6-minute walk test, which has been very popular, in this COVID time, where one has to just, the measure the distance walks in the maximum distance walk in 6 minutes. And similarly, we have done, one paper in which we predicted the 6-minute walk test, from different easily measurable obesity as well as anthropometric parameters. So going to the next one, the cardiorespiratory endurance test is extremely important. CPT is important not only for health purpose but also for performance and also for sports player also. But the thing is, the most of the time people focus only on VO2 max, but there are so many parameters, ventilatory and metabolic parameters which you can use, in case of the CPT. Like for example, I can use, anaerobic threshold is here, then RC, respiratory compensation point is here. So anaerobic threshold as well as respiratory compensation point is a good point. And in between, you can see the isocapnic buffering, where basically your VE by VCO2 or ventilatory equivalent of carbon dioxide is relatively stable. And after the respiratory compensation point, what happening is your what you call the end tidal CO2 decreases, and your VE by VCO2, your ventilatory equivalent, increases, and there is also exponential increase of the VCO2 as compared to VO2. So this is the hypocapnic hyperventilation phase, and isocapnic ISSV. The different anaerobic and respiratory compensation point has been used apart from usual VO2 max. So these which you can use to do different paper publication as well as applied aspect also for the player, like like isocapnic buffering ISSV. They have been used sometimes to see the changes of the aerobic endurance changes with aging, or or seeing the aerobic fitness level in players also. And the biochemical basis is very important. These are the basic biochemical basis. Here, by using this point, we can see that there is dancing of the physiology, in the rhythm of the biochemistry. Yeah, like for example, the phase one or the one is where the lactic acid, we all know the lactic acid, there's increase in lactic acid, and because of that there will be increase in hydrogen ion as well as the lactate. And the bicarbonate, which is the main buffering here, it will be reduced. So in this way, but if there is too much increase in the lactic acid, then what will happen? The pH will goes into more like acidic side, and this has to be compensated by using lots of our buffer system in the body, and ventilation will also be increased. And in case of the isocapnic buffering here in this phase, what is happening is, because there is a relative equilibrium is there. That's why the ventilatory equivalent of carbon dioxide remains the same, as well as the n tidal carbon dioxide also relatively remains the same. But what happens when you cause a respiratory compensation point? Then if this threshold is crossed, then your ventilatory drive will be very, very high, because lots of lactic acid will be produced. Metabolic acidosis will be there, and there will be respiratory compensation for the metabolic acidosis which is being produced by your active muscle. And because of that, there will be there will be increase in your ventilatory equivalent carbon dioxide, increase in the ventilatory equivalent for oxygen, and there will be decrease in PaCO2 and increase in PaO2. So in this way, this is the biochemical basis, and these are the different parameters, commonly measured parameters, which we can use. Like anaerobic threshold, we all know that how much important is anaerobic threshold, especially for elite players, where they have reached the ceiling of their genetically determined VO2 max, because the percentage of the utilization of VO2 max is as much, or in fact, maybe more important than your VO2 max in case of the elite player, where they have already reached their plateau phase, genetically determined ceiling level of VO2 max. This is me and with my friends measuring VO2 max, all this thing, and this is basically in Sai Bangalore. So, and this is the AIMS New Delhi Respiratory Lab. So next, going to the clinical aspect of the CEPT. Clinical aspect is very important because the different cardiologists, different respiratory physician, as well as the anesthesiology, they are coming up with this, CEPT, because the clinical aspect is very important. VO2 max measurement as well as other related metabolic, as well as the ventilatory parameters are so much important, where you can have a differential diagnosis of what is the limiting factor for exercise, what actually causes the exercise. Like suppose VO2 max is basically three systems. It's very important, like for musculoskeletal system where mitochondria is there, then the cardiovascular heart in your cardiovascular system, where the oxygen which has been inhaled by your lungs has to be provided to the active muscle, and all the the like the metabolic the end product, like VCO2, carbon dioxide, has to be removed uh, uh, from this. So that's why, and a coordinated working of three systems is extremely important. Not only three systems, there are also other systems, but mainly three systems is very important, like musculoskeletal system, cardiovascular system, and respiratory system. And at this each point, different parameters can affect them. Like for example, obesity and ear for obstruction can affect at this level. Or if there is any heart problem, then your circulatory as well as cardiovascular system will be affected. Where hypertension and all this will affect at this phase. In the same way, if there is obstructive or restrictive, lungs problem, lung disease, or there is some abnormality in the chest wall or infiltration, or it may be, a primary pulmonary hypertension, vasculitis, thromboemboli, all this factor will affect. So enhance your exercise capacity, your endurance capacity will be affected by so many a point. And by doing CPET, one may be able to roughly get an idea of what may be the underlying principle. Suppose this is your peak VO2, because many a times we are not able to achieve the plateau phase of the classic plateau phase of the VO2, which we call VO2 max, where in spite of the increasing your workload, your VO2 doesn't raise, and it basically becomes plateau. But unfortunately, not what to say, most of the time, which practically what we see is that instead of the VO2 max, what we get is the peak VO2, where where all other endpoint parameters or terminating parameter of your CPH, like your RER should be more than 1.1, and all this stuff will be reached, and you have to terminate the the exercise. And in that case, the VO2 measure is known as peak VO2. If the peak VO2 is considered to be normal, where it is more than or equal to 85% of the predicted value. If it is less than 85, then you have to go to the anaerobic threshold. And anaerobic threshold, it may be normal or low. If it is normal, what you see normal, that it should be more than or equal to 40% of your predicted, the value. If it is normal, then you have to see the breathing reserve, and depending upon whether your breathing reserve is normal or low, then you can classify, you can give a rough idea what may be the the positive factor for exercise limitation. Like for example, if in case of the low peak VO2 with anaerobic threshold is also low, and if the breathing reserve is normal, then it will be circulatory impairment. If the breathing reserve is low, then it can be mixed lesion may be there. And suppose the anaerobic threshold is normal, but peak VO2 is low, and the breathing reserve may be normal, most of the time normal, in case of if there is a poor effort or deconditioning is there, or coronary artery disease is there. If the breathing result is less, then it may be ventilatory impairment. Then what the rule of thumb, what we generally use is, if the RER is less than 1, especially if it is less than 1.1, or especially less than 1, and if there is no underlying metabolic abnormality, then the peak VO2 decrease maybe, or even if it is a normal, maybe because of the poor effort or anxiety may be there, or the disease may be in the mild stage. So this is one algorithm. There are so many other algorithms also. So in this way, there are different algorithms which are very helpful for differential diagnosis of different conditions for limiting the exercise capacity of the patient. And also let's come into the more applied aspect where let's focus on running, because running is a form of endurance exercise. You being an exercise physiologist or sports and exercise medicine doctor, the people usually comes to you asking about what type of the running pattern should I do, what are the form and all these things. So what the classically what we see there in case of the rear foot running, where the point of the contact is with the heel contact is there, and in that particular point you can see that there is impact peak is there, and this is not there in case of the what you call forefoot running or barefoot running or non-suit running. Here in the forefoot running, your point of contact is usually the forefoot, and in case of the midfoot, it is the midfoot. And for the barefoot, most of the time is they basically run with using their forefoot. So basically, what happens is the more adherence or the frequency is there, and the more less the stride length is there. Most of the time, what happens is you will be running more on your midfoot and forefoot as compared to your rear foot. And since because of this the impact peak impact, which is in vertical ground reaction force, which is not there in case of the forefoot running or barefoot running, it has been presumed that this rear foot running may be associated with different type of the running injuries also. Another point apart from the injury, which is more important for the players, is the running economy. That is, at particular intensity of exercise, how much is your oxygen consumption. So running economy, when they measure, they say that there is not much significant difference between a rear foot and a forefoot running. So what is the benefit? What is it? We don't know. Suppose if a person is habituated for the high heel strike or a rear foot running, then it will be very difficult for you to change it. So sudden change should not be there. If change is there, then proper conditioning and it should be done very slowly with proper conditioning. And when one see the pattern of the injury, in case of the different foot strike, for example, if there is more likely for the injury of the foot in case of the non-rear foot strike, like forefoot strike and mid-foot strike, like it may be because of the metatarsals, metatarsal problem may be there, or plantar fasciopathy may be there, or Achilles tendinopathy may be there, because of the when you strike is when you contact the ground with your forefoot, what is happening? Eccentric contraction of what you call soleus and gastrocnemius has to be done in order to absorb the force. So if there is not sufficient eccentric strength, then injury may happen, and a chronic chronically, if it is there, then it may affect your Achilles tendinopathy also. And what about the ankle? The ankle is relatively the same, with more likely of the slightly more likely in case of the rear foot strike, whereas the leg issue may be there, in case of your non-rear foot strike, and but knee, if somebody has a knee problem, then it may be better, if he is using the rear foot strike, then it may be beneficial for him to change the running pattern into the non-rear foot strike. Same for the low back also. So in this way, approximate idea can get but the rule of thumb is what everyone is different. Your body has the tremendous capacity to adapt physiologically, and even if you want to change your running pattern, or whether you want to go into the from shoe running to minimalistic running or barefoot running, it has to be done in a very gradual manner, accompanied with proper conditioning of the muscles, and and all that, and very slowly, and in a very proper way, not abruptly. So this is my point here. So let's go to another one, that is the what usually asked by most of the courses, and or the one who are usually the weekend warrior, or who has just started the running, is a slow running or maphyton or MAF, maximum aerobic function running, is good or not. So according to the Mephiton, Dr. Mephiton has proposed that running heart rate maybe here one may be running at 180 minus S at the upper limit, and the lower range will be 180 minus S subtracted by 10 for the lower. So in this range, if one run, then he may be targeting fat oxidation, maximum fat oxidation. This is his idea, and this is and what what the usual notion is at this intensity. You are doing at a mild or moderate or a little bit of vigorous intensity exercise, not very severe exercise. So you can also modify 180 minus AS depending upon your whether you have just started or you have gone you are having a chronic condition, like in that case minus 10 beat per minute can be subtracted, or if you are very experienced, you have run a regular runner with this MF running technique for 2 years or more than 2 years, then 10 plus 10 can be added for the upper range of the running heart rate. So when I plotted the 180 minus A's by using two different prediction equation for percentage of maximum heart rate, that is one is for 220 minus S, two is what was proposed by the Tanaka et al. 2001, that is 208 minus 0.7 into S in year, and this is the percentage heart rate, MF heart rate in percentage of heart rate. So this is what we generally see. So when a person with increasing age, there is the MF running heart rate is generally less. But you can just suppose if I for a like 40 for a 40 years old, then it will be 76.5% of his heart rate maximum. If one is this is the upper limit for MAF running, or if we are using the 220 minus S, then it will 77.1%. So in this way, but from general from this general idea, the general the conclusion which we can find out, that it is not compulsory that by using 180 minus S will your exercise will always be in a mild moderate stage. See, it can be, and most of the time it can be, in fact, for a younger individual, it can be the vigorous intensity also. Just remember the grading of the exercise depending upon your percentage heart rate maximum. And one important factor is the fat max zone, the maximum amount of your body is utilizing fat. That is known as fat max zone. It is therefore 5 to 72% of your VO2 max. Now this percentage can be converted into heart rate, and you will be approximately knowing what is your fat max zone. But this is basically for a trained person, and for this is basically for trained person, and for a layman, or for the person who has just started, the fat max may be very low intensity also. So you can basically compare the fat max, whether you're by using 180 minus S, whether your exercise heart rate is falling in the fat max range or not. Another point which is basically asked by many is regarding the load to the joint if one is doing slow running. See, the load to the joint and and a predisposition to different running injuries, as well as for knee osteoarthritis and all the hip osteoarthritis, they are all multifactorial reason. Like if a particular person is low in fitness, very obese, very high weight, then then he may be prescribed starting prescription of the non-weight bearing exercise in order to build up the required conditioning as well as a cardiorespiratory fitness. Then after that he can be started with the slow running, and then slowly as the fitness and the muscle adapts, then you can progress into more high intensity interval training, HIIT, or sprint interval training, and all these things. So before going into the joint load structure, you have to understand the basic biomechanics or the gait cycle. Like for example, if you compare to the walking and the sprinting, the walking you can see that the stand phase is more as compared to the swing phase, where your leg is not in contact with the ground. But if you increase the speed of the running, like sprinting, then what will happen? Then float phase is also their swing phase. The percentage of the swing phase increases, and the float phase means your both of your leg are floating in the air. So that is there. So when you do a contact, like I have already said that if you do a contact by using your forefoot, then what will happen? Your this muscle, your this posterior the plantar fascia like gastrocnemius soleus will be eccentrically contracting and absorbing the load, and that's why you have to eccentrically build up this particular muscle. And if we see the vertical ground reaction, then vertical ground reaction has an approximate linear a kind of the not so linear but a kind of the roughly linear relation with the speed of the running also. Like for example, if a particular person is running at 7.2 kilometer per hour, then the load may be 1.5 times his or her body weight. So if we increase the running speed to 25.2 kilometer per hour, then it can go up to 3 times the body weight. So what is the rule of thumb is in case of the running, it may be 2.2 times your body weight, or the approximate a little more than twice that of the load which you experience during your walking. So slow running, for a novice, for a starting person, uh, is good because you may be targeting your fat max zone as well as your loading on the joint may be reduced. But one thing which you have to or understand is running does not predispose to knee osteoarthritis and all this stuff. There is a misnomer that running causes all this thing. As long as your weight is not too high, you have a sufficient muscle conditioning and sufficient fitness and require neuromuscular coordination, then running does not cause or does not predispose. And the running, the volume is also important. How much is also important. So basically, for a higher advanced patient or the advanced client, you can prescribe the high intensity interval training also, which are very much important. If you want to increase your cardiorespiratory fitness and which are also finding their usefulness among in exercise prescription for fat loss or for diabetic patient and all this. So one has to know, what there are the different exercise regime is concerned. I'm not going to into the detail of different type of the exercise regimen like LSD, MICT, ISIT, because these are all basic ideas, and I assume that you already know this basic stuff. So let's go into the basic principle of the resistance training. The basic principle of the resistance training is if your weight, your set, number of repetition, your rest interval, everything depends, your intensity, everything depends upon what is your goal. Suppose your goal is toward muscular endurance. If you want to build muscle, then what will happen? Then your repetition will be higher. You will have a higher repetition. That means your load has to be reduced. And if you are focusing more on the strength, then what will happen? Then your because you will be lifting more heavier weight. That's why your repetition will be a little bit lower as compared to muscular endurance. So by using this principle, then there are different general guideline which you have to adapt because there is a principle of individuality is there. You have to adapt depending upon a particular person. Like suppose if you want to target a strength training, then the load can be equal to more than 85%, some or 90 to 100%, and the repetition may be less than 6 or 3 to 6. The set may be 3 to 5. 1.5 to 2 minute rest can be given, and the speed may be controlled. If the speed is explosive, then you are more targeting the power. Power is nothing but a force into velocity. So in this way, and for example, hypertrophy. If your focus is more on hypertrophy, then your RM may be percentage of RM, one RM may be 65 to 85% or 70 to 90%, and your reps may be 8 to 12 or 6 to 12, and the set may be 3 to 6 or 2 to 3, and this may be your rest interval. And regarding your hypertrophic strength training, we generally go slow and eccentric because what is happening is, in case of the eccentric, the force is directly proportional to velocity. So if you do very fast, then the chance of the injury is very, very high. So it's always better to go slow on eccentric, where you will give sufficient time for the tension to develop, because the tension is related with the muscle hypertrophy also. And muscular endurance also. This is the muscular endurance, where you can do the sports specific also. These are the different guideline, and depending upon this parameter, you can modify according to your practice. Now, this is the famous Hensman size principle, where we can see that the type 2 fibers are always recruited when the force production has to be very large, and hence they have a very high electrical threshold. So suppose if you want to recruit a type 2 fiber, then without having much or heavier weight or lighter weight, then you have to do a training up to the failure, where fatigue comes into the play, and because of the fatigue, the recruitment of the higher or type 2 fibers happens, the threshold decreases. The same principle is also we follow, where we purposefully let the accumulation of the metabolite, like in blood flow restricted training, where you will be able to do exercise training at a relatively lower intensity, but still getting the benefit of doing exercise at a relatively higher intensity. So in this way, just by knowing the basic physiology, you can modify, you can mold according to your benefit. But the most important thing which I observe is strength training has been neglected so much. Always people always focus on cardiorespiratory fitness. Strength training is very important, and one has to incorporate strength training even for the runners also. Strength training is important, and the training, the fiber change in training is very, very less than 10%, even if it is there. So less than 10% of the fiber type transition may be happen because of the training. But people mostly ask that fiber type is important or not. Fiber type is important genetically, mostly genetically determined. But what is important is you have to proper training is also very important. So next, going to the next one, where another important basic concept is the eccentric and the concentric training, which comes under isotonic muscle contraction. Yes, I have already said that the eccentric training, this is the force velocity curve of the eccentric as well as the concentric. Eccentric, what we can see that when the force is increases, then what will happen? Velocity also increases. Velocity also increases when the force is increases. But in case of the concentric, what has happened is that if the velocity is low, if the velocity low, then only you will be able to do more force. That's why in order to lift a weight, you have to lift it very slowly. But in case of the eccentric, the opposite is there. Since there is very high chance of the force production in case of the high velocity, injury chances also very here. That's why we focus mostly slow eccentric training. And eccentric training has a is very much useful for muscle hypertrophy, because it's one of the type of the exercise accompanied with stretching that stimulate the satellite cell also, that is responsible for the muscle buildup. Since the more force more force in the form of the active plus passive, for passive tension is there, and because of that, injury probability is very, very high. And also DOMS, delayed onset of the muscle soreness, which one observe after 24 or 42 hours of training, intense unaccustomed training. So this one has to be very careful. But the most important thing is eccentric training form the basis of the stress shortening cycle, which we observe in different sports injuries, with different sports performance also, and also plyometric, plyometric exercise. Like for example, this is the counter movement vertical jump is an example of the plyometric, where stress shortening cycle is there. A little bit stretching of the quadricep is followed by what we call the concentric contraction of the quadricep. So this is the paper which we have published for the vertical jump also. And since vertical jump and other strength parameter like hand grip, dynamometer strength parameter, they are they are good predictor of all cause mortality as well as morbidity. That's why prediction by using easily available anthropometric parameter, which you can do and may be useful also. And this is an instrument which we generally use to measure the isokinetic strength. Like this is an isokinetic machine or variable resistance machine, which are very much useful for the the prediction and the measurement of the strength curve of different muscles. or we can easily find out the ratio of the quadricep to hamstring and all this, which has a practical applied aspect in case of the injury prevention or rehabilitation purposes. So this is basically the strain curve. Strain curve is nothing but the isometric torque angular force against the angle of the joint. This is the angle of the joint. Suppose you are holding a fixed weight, but the ability to produce the force by your muscle changes according to your elbow. That means at a particular intensity, at a particular adjoint angle, you will be able to produce maximum force. And if you are using weight which is less than that, then the muscle here will maybe suboptimally loaded. Whereas if you do a very heavy weight, then what will happen? Muscle here may get injured at this range of motion, or you will not be able to do full range of motion exercise because your muscle will not be able to support at this extreme range. So in this way, strength training knowledge is very important. And strength training may not be in this in this curve always like inverted U curve always for multi-joint joint exercise. Strength curve may be ascending, it may be descending also. Let's take an example of the ascending, like bench press. Here we can see that. So when the person extend his elbow and flex his arm, then what will as he raise the weight up, then we can see that the ability to produce the force, that is concentric force, is lower when the weight is near his starting point, and the ability to force will be higher in case of the higher. So what will you do by using a fixed weight? If you want to differential loading of the muscle, because the principle of a progressive overloading says that the muscle or your system has to be optimally loaded, progressively loaded, so that the adaptation happens. If the progressive loaded is accompanied with a proper recovery, then what will happen? You will be going into the what you call the super compensation phase, not go into the overtraining phase. So the optimum loading is very, very much important. So optimum loading, what we can do is by just hanging a chain, where in the initial phase the weight of the chain is supported by ground, and if you lift, then what will happen? The gravity will come into the play. So gravity will come into the play here at a space where your muscle has the ability to produce more force. Same here, you can use a resistant band also here, and same here, the chain may be hanging also. Another important point is the applied aspect here also. Suppose if bench press here at this point, eccentric contraction of the whatever pectoralis major or muscles also happen, where rupture. See, you can see the rupture at this particular point, where the force, the ability to produce force by the muscle is minimum at this point. So at this particular point, the chance of the injury is very, very high. The sporter has to be very, very careful. And the person should not go with excessive weight at a time also, because the risk of injury is always high. So, but the thing is, training curve, if you want to do like isokinetic machine, variable weight training machine is there, but they are very cumbersome and high cost is there. So may not be accessible to lots of there. So what we can do is we can approximately design, a rough that machine, where you can use a isometric dynamometer by using EMG, and you can measure the angle by using goniometer, and you can plot it the graph, isometric strength defined. So in this way, you can approximately get the strength curve of your the elbow flexor and elbow extension. And if it is down here, if this it can be bring down, then you can insert your leg, and you can do the approximately strength curve for knee extensor and knee flexor also. So this is the particular device we have applied. We are in the process of the application of patent also, and this is a practical which has been accepted in AIMS as a UG as well as PG practical there. So this is important, where you can measure the strength curve, and you can see the optimal angle also. Just imagine the optimum length for force and length tension relationship, which we classically do by from frog frog gastrosoleus muscle, gastrosoliatic muscle. So this is an example where instead of doing in frog, you can basically do in a human being by using some simple instrument. For force measurement, then you have to and for EMG you have to rely on some kind of ADI or some power lab or some many other device are there. So let's go into the more into the applied muscle fitness and body composition. Like the aerobic, we are always focused. But one thing which I want to say is anaerobic testing. Like Wingate is the classic anaerobic testing. Wingate test. Wingate test. But the Monarch cycle ergometer, which may not be available to many, what they can do is anaerobic testing can be done by using the RAST, running associated sprint test. And the cycling may not be sport specific for someone who is running, who is a weight bearing exercise. So in that way, RAST test is very important, where basically 35-meter distance is there. One person, the athlete, run from here to here with maximum sprint, and you record the timing here, and in between you give a rest interval of like 10 seconds. You give, and you can do laps of of 6 or so. Then you can calculate the fatigue index. You can calculate maximum all this stuff is there. So running associated sprint test is one of the fantastic tests. By using this as many and using the principle of the exercise prescription, you can do different type of the paper publication like we have done, like fatigue index by using the RAST, and the body composition using Herpendale skin fall caliper, or bioelectric impedance. By using that, you can do you will be able to do different publication, as well as that will be useful for giving exercise prescription, as well as for intervention also. So so let's go to the next phase. So basically, this is a software is also there, very nicely given everything. Then clinical and interventional exercise physiology, how you can do intervention. The intervention can be in the form of the sports and exercise medicine, which sports medicine branches the basis form. The basis is formed by performance related sports and exercise physiology, whereas exercise medicine the basis is formed by clinical exercise physiology. And also lifestyle medicine is also very important, where you consider the different lifestyle changes, because each and every most of the non-communicable disease what we are facing is because of the lifestyle, unhealthy lifestyle. So lifestyle medicine can be done, and depending upon different parameters, like different physiological therapy you can give, like even rehabilitation is also a type of kinesiotherapy, is also a different type of interventional exercise physiology application. Then also the interventional exercise physiology can also be done in the form of space, aerospace, or aviation medicine. It can also be done in the form of your high altitude medicine, or a mountain medicine, or mountain physiology, where this is just an example, like your VO2 max at sea. This is a VO2 percentage of VO2 max sea level, and if you're with increasing altitude, it's linearly approximately it follows a linear decline. After say approximately around here, there is 1,500 meter, or 1.5 kilometer. Mount Everest is approximately around 8.85 kilometer. So if you build up the baseline VO2 max, then your loss will be relatively less. So that's why fitness testing, as well as exercise fitness build-up is so much important in case of the high altitude mountain medicine also. And I request everyone to establish the labs just like that, where even if you don't have any kind of high-fi costly instrument, also with your basic knowledge of physiology, clinical physiology, interventional physiology, you can do exercise prescription, and the clinical care you can provide to normal as well as the patient of different non-communicable diseases, etc. And the basis of the exercise physiology, one can also become like a clinical exercise physiologist, or bio kineticists, which is most common in South Africa, or it may be kinesiologists or exercise specialists or kinesiotherapists, strength and conditioning specialists, or cardiac respiratory rehabilitation specialists, and MSK, musculoskeletal interventional physiologists. Also, these are a different field where clinical and interventional exercise physiology is extremely important. So let's go into the concept of the exercise medicine. The concept of the exercise medicine has already been focused by different speakers, and what I basically focus is I want to focus is exercise is medicine. It's extremely it's what to say, exercise is indeed a medicine, and hence that's like any other medicine, it requires prescription, and the prescription can be done under different fit BP, like for frequency, intensity, time, type, volume, progression, pattern. So it can be done in this way, and in different non-communicable diseases, this exercise is so much benefited. You can see as compared to drug or surgical benefit, how much is the exercise benefit is there. So let's go into the diabetes. It is very much common. So this is the fit principle. Depending upon exercise prescription can be done. For example, aerobic exercise, resistance, like flexibility training can be given, like frequency, like 3 to 7 day, per week, or equal to or more than 2. Non-consecutively, preferably it may be 3. Flexibility maybe 2 to 3 days. So like this, in this way, you can give exercise prescription for diabetes. But what is more important is there are certain few points which you have to remember, especially in case of the type 1 diabetes. Like for example, if if the blood sugar is more than 200 or 250 with urine ketone, then it's not better to do exercise. You should not go ahead with exercise. Or if it is more than 300, even if urine ketone is not present, then it's better to avoid exercise. The preferred blood sugar level is around 120 to 180 milligram per deciliter, and depending upon the exercise intensity, you can modify the diabetic drug, including insulin, because the exercise has an independent effect on glucose receptor. So the rule of thumb regarding the consumption of the sugar is also very important, because exercise can cause as short as well as prolonged post-exercise hypoglycemia also can happen. So rule of thumb is you can consume around 20 or 15 to 30 gram of carbohydrate at onset or every 1 to 2 hours of vigorous intensity. So if you want to go into further detail, then you can refer to this table where, for example, if for a low activity for say half an hour, and if your blood sugar is less than 100, then it's better you take a 10 gram of carbohydrate. If it is more than 100, then there is no need to take carbohydrate. In this way, for moderate intensity, for strenuous intensity, vigorous intensity, in this way you can plan accordingly. But once again, I'm telling you, this is just a rule of thumb or guideline, and you have to modify in your practice depending upon the patient, because individual variability is also very, very high. So let's again go to the another factor where sorry, yeah. So let's again go to the exercise prescription for another common chronic problem what we are facing is hypertension. Hypertension in same way in case of the fit principle, like for frequency, for aerobic resistance and flexibility, you can do in the sense how much should be intensity, how much should be the type of exercise, and the time duration also one can prescribe. Because what is important is exercise exercise has a very much good effect on hypertension, where you can see that in case of the population with hypertension or systolic blood pressure is more than 140 millimeter of mercury, the reduction by exercise is more than by medicine also. So this is important. But few rules of thumb which you have to remember, like for example, no exercise should be done if your resting blood pressure is more than 200, like systolic equal to more than 60, or diastolic more than 100, or 120, or if there is a target organ problem like retinopathy, like ventricular hypertrophy, it's better not to do exercise. And exercise systolic blood pressure should not go more than 250, or diastolic should not go more than 120 or 150 millimeters of mercury, or there should not be a rise on diastolic blood pressure more than 15 millimeter of mercury, or fall in systolic equal to more than 10 millimeter of mercury, equal to more than 15 millimeter of mercury. So this is common for all the exercise, and this is what I want to. This is just a rule of thumb. So it's always better if you keep the exercise systolic blood pressure less than 220 and diastolic equal to or less than 105. And for those who are having, diabetic retinopathy, in case of the diabetic patient, or in case of the hypertension, it's always better to avoid a Valsalva maneuver in instance where the risk of the suddenly increase in your blood pressure is very, very high. So another important factor which we are seeing commonly is overweight and obesity. So in obesity and overweight also, we can similarly follow the principle of the exercise with prescription like a fit principle here. You can see here, like for the intensity, if the intensity can be for aerobic 40 to 59% of U to R, or HRR, that is heart rate reserve, and it may be progressed to equal to more than 60. The resistance training may be done around 60 to 70% one, it may be increased gradually. So in this way, you can do the flexibility training also. And the rule of thumb is you can approximately aim for 0.5 to 1 kg per week of weight reduction. And this can be done by, you can reduce the calorie consumption from 500 to 1000 kilocalories per day. The aim is approximately equal to more than 3 to 10% of weight loss over 3 to 6 months is helpful. But in order to, weight loss of more than 5 or 10%, then aggressive, the aggressive treatment, or what you say, the aggressive management has to be done. Like, one can follow the time restricted eating of 6 to 10 hour per day, or intermittent fasting. Or there is also many literature, about low carb, high fat diet, or keto diet, and all that stuff. So these are some important points which I want to highlight regarding exercise prescription. So let's go to the exercise injury and illness. Exercise, the benefit as well as the health and risks is just like this. If you do excessive sedentary activities, the benefit is very, very low, the harmful effect is very, very high. And if you do very high load exercise also, the relative harm or risk may be increased. But the good thing is the current recommendation of exercise given by AHA, or the American College of Sports Medicine, or WHO, they are in such a way that if you can increase also, the health risks will be reduced up to a particular point. The health risks will be increased only when if you do very high intensity of exercise. It may be very high intensity, or it may be very high volume, and all these things. And this is one of the concept of acute versus chronic workload, where acute is the previous where the acute is the what you call the previous week exercise, which is correspond with the fatigue, and the chronic is the average of the previous 4 weeks, which is the approximately which correspond to your fitness. So you can calculate the ratio, and the sweet spot of the acute chronic workload is approximately 0.8 to 1.3. If it is more than 1.5, then the risk of injury is very high. So you have to balance between your acute, which is fatigue, and chronic. So in this way, the injury also can be predicted or can be prevented. Another important, which is important, is also the effect of exercise with immunity and disease susceptibility, especially in case of the COVID era, where you can see that the disease susceptibility high in case of sedentary, and it is also high if there is excessive overtrain or exhaustive intensity of exercise for a very prolonged time, especially in very environmental challenge or very extreme environment is there. But one also suggests that the risk of this susceptibility is also lower. Even if exercise intensity is little bit increased in case of the highly elite player also. Instead of the BACI-SEP, they suggested ISSEM also. So different concept is there, but the rule of thumb which we have to follow, if a particular person is having some fever or upper respiratory tract infection or something like that, we can follow the neck check rule of thumb. But again, it is just a rule of thumb. You have to modify depending upon your requirement. And for COVID, it may not be applicable. One have to remember. Like for example, if your symptom, you are having symptom below the neck, like muscle pain is there, fever is there, GIT problem is there, it's always better to avoid exercise. And especially when your resting heart rate is more than 10 beats per minute as compared to the earlier resting heart rate. And if your symptoms more confined to the above your neck, like for a running nose is there, a little bit of a sneezing is there. Okay? So in that way, you can you can start a very light intensity exercise for say 10 minutes, and then can be slowly increased for and maybe you may focus more on skill training as compared to the hard exhausted exercise, and the intensity may be less than 70% of HR maximum or less than 80% VO2 max. So in this way, a relative rough guide is can be obtained by using the rule of thumb neck check criteria. But COVID, it may not be applicable. You have to individualize everything. Another important point for clinical and interventional SIS physiology is your ability to assess, what you call muscle imbalance and different MSK, musculoskeletal, pathologies, musculoskeletal injuries, chronic as well as acute injuries. Very important. So the art of touch is very important, and the star is the STAR is what we generally follow, where S is means sensitivity or tenderness, T is for tissue texture, asymmetry, range of motion, which you can feel when you touch the client body or the patient body while examining or while palpating. And this is just an example of a muscle imbalance which was proposed by the Jandas, and it may not be accurate also, but this is just provide a rule of thumb. So one need to be very very cautious. It may not be applicable as such, but this give a good what do you call a rule of thumb. Like for example, if neck region, if there is a problem is there, then it may be because of the upper cross syndrome, where the tightness may be here in case of the sternocleidomastoid or pectoralis here tightness, and the tightness again crossly the tightness or facilitated like the upper trapezius or levator scapulae. Sorry for the spelling mistake here. So levator scapulae muscle may be there, and the weakness, inhibited or lengthened muscle may be deep cervical, the flexor muscle, or the lower trapezius serratus anterior may be there. So you may focus on strengthening of this muscle, and you can focus on a little bit manual therapy, or if there is a trigger point is there, then you can release the trigger point by using dry needling or ischemic pressure. So all this thing can be done. Intervention can be done depending upon the upper cross syndrome. In the same way, for a lower cross syndrome, like for if a particular person is having low back pain or some issue is there, then the tightness may be there in case of rectus femoris, or iliopsoas muscle may be tight, or the tight muscle may be thoracolumbar extensor may be tight. Weakness, the abdominal muscle like may be weak, and gluteus medius, maximus minimus may be weak. So strengthening and stretching of this muscle can be done. And muscle re-education is also important. Muscle, like for example, if you have a back pain, all this thing, then you may focus on transverse abdominis. You can focus on the multipedals. In addition to other muscles, global as well as the local, dynamic stabilizer, and the core stability is also very important. So this is just an example of how muscle imbalance may be there. And let me go to little and just like a muscle, we can also focus on like stretching or neural stretching, or like neural flossing or neural slider and tensioner of the different muscles. The different nerve may be there, like upper limb and lower limb. Like in this picture, what you can see is that this is just he tries to just approximate the nerve, by using this long, yellow tube here. So by using this exercise, it can be supplemented, and they are very much helpful also. The most important, a factor for exercise being so much effective as a exercise therapy in the form of exercise therapy is because of the phenomenon of mechanotransduction. So, like for example, if you see a heel drop is there, like a heel drop, an eccentric contraction is very much important in case of the Achilles tendinopathy, like Alfredson heel drop protocol for soleus as well as gastrocnemius for especially mid-insertional, Achilles tendinopathy. What is happening is if you do, exercise will cause a sliding of the collagen. Now, this sliding of the collagen will causes more intercellular communication via gap junctions as well as communication with the nucleus, and ultimately lead to the upregulation of the protein synthesis, and the repair of the tendon or repair of the tissue, as well as the regeneration may also happen. So this is the principle of the mechanotransaction, and hence exercise is so much important in case of the MSK also. So basic component of the rehabilitation as an exercise physiologist, as a MSK exercise physiologist, one has to know is it always start with the muscle conditioning. Muscle conditioning, in the form of the muscle activation, muscle re-education, the muscle strength, power, endurance training can be done. Then neuromuscular coordination is important in the form of proprioceptive balance exercise, by using a trampoline or rocker board, or some unstable or physio ball. Then you can progress into functional exercise, which can be slowly progress into sports skill or sports specific exercise, and this has to be there has to be a biomechanical correction. If there is a biomechanical abnormalities there, then it's better you correct it in order to prevent future occurrence of injury. Then it should be lastly it should be accompanied with a psychotherapy, or psychological touch should also be there with the cardiorespiratory maintenance of the cardiorespiratory fitness, should be done with using different cross training and all that stuff. So kinesiophobia is one of the important factor where, for example, say after ACL reconstruction, the player is not able to go into the field. So psychology is also very important. So different psychological tool, rehabilitation you can do, like imagery training is there. So, and different relaxation technique, and different counseling session. So this has to accumulate with regular rehabilitation. Next one is the acute injury. How we have to take care of the acute injury as a clinical and interventional MSK physiologist. Earlier, we mostly focus on RICE, that is, RICE, rest, icing, compression, elevation. This then it goes into police protocol, and then now we are following the peace and love protocol also. So what is happening is, you have to protect them. Then you have to elevate that particular part. Anti-inflammatory, as well as icing is we generally too much icing is also we generally avoid. Why? Because some amount of inflammation is always required for healing. This is one has to know. This is very important. And also compression you can do, like proper education. You have to provide the patient, the injured person, a proper education as a part of the rehabilitation, as a part of the treatment also. And load. Optimization of the load is very important. Optimization of the loading, some relative race has to be there. A complete race is always determined. It has to be relative race. So loading has to be very, very careful. And the vascularization exercise, many pain-free vascular activity to increase the blood flow may also be done, and the proper planning of the load is very, very much important. And you have to keep the psychological factor. Optimism has to be there, and ultimately exercise is very important. Movement is very important, and exercise is as a part of the rehabilitation, as a part of the even for acute injuries also important. So pain-free exercise, and focusing more on optimal loading, optimum vascularization, optimism. All these things is very important. Then let's talk. Let's go into another important topic, which is known as the EAMC, Exercise Association Muscle Cramp, where the knowledge of exercise physiology is very important. Like premature fatigue may causes what you call the activation of the muscle spindle, whereas inhibition of Golgi tendon, the organ, which will causes uncontrolled contraction, and the exercise associated muscle cramp may be there. So how you want to break this chain, or what will be the immediate by using this baseline pathophysiological knowledge, what you can do? You can do passive stretching. Passive stretching is one of the most effective immediately you can provide to the player or the person, where passive stretching may be maintained up to 20 minutes also, or till the fasciculation stop. And one which you can do is the reciprocal inhibition. That is the antagonism. The muscle can be contracted, which will causes the reciprocal inhibition of the muscle which is having the cramp. Or electrical, the stimulation of the afferent tendon, the afferent fiber may also be done. And the icing may be accompanied with the passive stretching. Why? Because you want to offset the DOMS, possible DOMS, delayed onset muscle soreness, which may happen because of this minor injuries which may be associated with EAMC, that is exercise associated muscle cramp. So this is a book which we publish on the flexibility in stretching, where we focus on different stretching and different flexibility component is there when I was working as a sports medicine doctor in SAI and ARC Imphal. So let's go into the next phase of clinical and interventional exercise physiology. Is as far as also for sports medicine guy, the sudden cardiac death issue is very important, because sudden cardiac death is devastating, and even if because of the high media coverage, even if it may have relatively lower frequency as compared to the sedentary person for elite player, but one episode is enough to causes all the danger, all the apprehension, all the fear among the players as well as among the sports medicine doctor. Most important common cause for the sudden cardiac death for less than 35 years, any kind of the structural congenital issue like hypertrophic cardiomyopathy. For older athlete, it may be coronary artery disease and atherosclerotic disease. They are most of the time they are the causes for more than 25 years. And another one type of the cardiomyopathy which I want to focus is known as Philippines cardiomyopathy, where the strenuous exercise like a marathon for a very long time without any adequate recovery has been proposed to causes the Philippines cardiomyopathy, which may be responsible for sudden cardiac death in highly elite endurance ultra endurance runner. So the the basic proposal, what they suppose with the training, the trainers training will cause catecholamine oxygen demand, preload, afterload. Preload is very much increases, and all this the abnormally they may be associated with increased cardiac enzyme like troponin, CKMB, BNP, like brain natriuretic peptide may be there. So the increase may be there, and this acute effect may result in right heart strain like right atrial or right ventricular dilatation or right ventricular hypokinesis, leading to the diastolic dysfunction. Then after this, all these factors are accumulated for a subacute kind of subacute effect will be expression of different fibrotic markers, or fibrosis will be the cardiac fibrosis will happen because of that stiffness will also happen, and this will ultimately lead to more diastolic dysfunction, and also systolic dysfunction may happen, and the zone of the fibrosis may be there, which may be subject for increased ventricular fibrillation. Another problem may be there, like for example, in case of the chronic effect, it may be increased ventricular fibrillation may be there because of that sudden cardiac death can happen. Atrial fibrillation, like atrial, arrhythmia and atrial fibrillation are mostly common in endurance players also, and the cardiac size maybe increases, which we already know. The adaptation of the heart, that is eccentric hypertrophy of the heart, and the patchy area of the fibrosis, which one can identify by using the cardiac MRI with lead gadolinium enhancement, which may be investigation of the choice here for this Philippines cardiomyopathy. And because of this thing, left ventricular mass and all these things, and this cycle may continue, and it may ultimately lead to ventricular fibrillation and the sudden cardiac death of the patient. So what is happening is basically if more what you call, this is a Frank Starling curve where stroke volume and the ventricular and diastolic volume, and the ratio is the basically the ejection fraction. So what we can see that if more demerit is there, where disruption of the fiber because of the very high or constant preload is there, because the Frank Starling says that more preload, the more will the force of contraction. But what will happen if chronic stress of highly increasing preload is happening again and again for a very long time? Then what may happen is, if excessive preload is there, with ventricular and diastolic volume is there, just as we see in case of the pathological condition. This is for pathological condition, but in this what you call fidefid cardiomyopathy also, there may it may started with the disruption of the fiber because of the excessive stress. Then different what you call the fibrosis, fibrotic increased fibrosis may be there, and stiffness will be there, diastolic what you call diastolic dysfunction will be there, and because of this what you call fibrosis, then what will happen? There is increased chance of ventricular fibrillation and the sudden cardiac death of the player may happen. So this is important. So one thing which one has to know is what is the difference between athlete heart and the pathological heart. It is because the athlete heart is basically the physiological adaptation to the training, and pathological heart like hypertrophic cardiomyopathy. The most important factor which one has to know, athlete heart is the athlete septal thickness is rarely exceed 15 millimeter. And the left ventricular enlargement is usually there. It's there always, and the dimension may be more than 55 millimeter. But if you see the pathological adaptation, hypertrophic cardiomyopathy, for example, the diastolic and diastolic volume will be less than 45, so filling will not be there, the stiffness will be there, and diastolic dysfunction will be there, and the septal thickness is usually more than 15 millimeter mercury. The gray zone is always there, where the thickness is around 13 to 15 millimeter mercury, or in men to 12 to 13 millimeter, 13 millimeter, not millimeter mercury, millimeter in case of the women. So this thing, another, if you are in a serious doubt of gray zone, then what you can do is you can ask the athlete for deconditioning for about 3 months or so. The thickness may reduce to 2 to 5 millimeter in 3 months of deconditioning may be there in case of the athlete heart. But in case of the pathological heart, this will not be there. So in this way, you can do what you call difference between athlete heart and pathological heart. So since ventricular fibrillation is one of the most important cause of sudden cardiac death, one has to know at least the basic CPR and the use of the AED, that is automatic external defibrillator. Here I have written a chapter on defibrillator, and it's available both on YouTube as well as in the website of the EPG Pathshala. So one can go there. And this is another, index of cardiac oxygen consumption uptake, which we generally use. Like it's called double product or red pressure product, which is basically the systolic blood pressure into heart rate. So you can prescribe the exercise in such a way that your double product is relatively less. So it depends upon your systolic blood pressure as well as heart rate. For example, if you want to do exercise prescription like only upper limb exercise as compared to lower limb exercise, the lower limb exercise usually has a lower exercise blood pressure as compared to upper limb. So lower limb exercise may be preferred as compared to only upper limb exercise if you want to prescribe to a person who is prone for cardiac issues. So this is the practical aspect, and another practical aspect is if you do CPET and if you find the positive the finding in the ECG, stress ECG, and you can note down the approximately red pressure product at that particular point, and you can always prescribe the exercise which is lesser than always less than that particular double product point. So this is also another important point for red pressure product or double product. So let's go to the another important point for now present situation, that is COVID. What is the importance of COVID and clinical exercise physiology? Rehabilitation is very important, and it has all the principle of clinical exercise physiology, where the rehabilitation of the COVID-19 has to be pulmonary as well as cardiac and exercise rehabilitation. It has to be multi-disciplinary, multi-dimensionally, different specialty, different doctors as well as a health professional from different specialties has to come together and provide a good, evidence-based rehabilitation for the COVID. So another point which one has to understand regarding exercise and COVID is the possibility of sudden cardiac death because of acute and subacute myocarditis and perimyocarditis. This has also to be kept in mind, especially with COVID. One must be knowing that COVID is a what you call thrombo inflammatory condition, where risk of thrombosis is also very high because of the chronic inflammation or hair going into hair wear of the immune system of the patient. So one has to be very careful, in case of the player or a person after COVID, going into sports. So the viral infection may cause different factors like heat exhaustion, post-viral fatigue syndrome may be there, viral myocarditis, and 5 to 25% of sudden cardiac death in athletes may be because of this myocarditis and the perimyocarditis. So that's why it's very important. And we have published a paper regarding the resumption of swimming, post COVID-19, and Indian Society of Sports and Exercise Medicine. These are some guidelines provided by this society, our society, and this is a part of a book chapter which I have written and is in publication process. So what is more 3 points which I want to highlight here is, in case of the players, any alteration in rate of perceived exertion, even if you don't have symptoms. So this is one has to keep in mind. Unusual and unexplained alteration in activity related, perceived of, rating of perceived exertion. Another important point is in case of the asymptomatic COVID player, asymptomatic, he is a COVID positive but asymptomatic. He or she has to restrain from intense exercise for at least 2 weeks. No sports participation should be there. With pneumonia, if there is no pneumonia and myocarditis for at least 2 to 4 weeks. No participation for symptomatic COVID positive person, but symptomatic but no pneumonia and myocarditis. At least 2 to 4 weeks. It's always recommended that high intensity exercise and sports competition participation will be there. If pneumonia is COVID pneumonia is there, then you at least 4 weeks. At least 4 weeks you have to wait. And if there is a pericarditis for at least 3 months, myocarditis at least 6 months. One has to wait. One has to assess using, like what I've already focused regarding the cardiac MRI, like late gadolinium enhancement technique for the fibrosis. So depending upon the investigation, the players, may or may not go return to the sports. For a recovered player, the player who have recovered from COVID with no symptoms for, for 7 to 10 days, and the first symptom onset should be more than 10 days. They may go to return to play, and the return to activity, return to play, for recovered player or recovered person should be such that the initial 2 weeks should be, at least 2 weeks should be of minimal exertion, minimal intensity of exercise, minimal exertion should be there. And the pre-COVID activity can be reached only after at least 4 to 5 weeks. So first, at least for first to 2 weeks, minimal exercise, and pre-COVID, activity can be achieved, after at least 4 to 5 weeks. This is important. And as I have already focused, medical evaluation as well as relevant cardiac, pulmonary, ergometry, like cardiac stress test, biochemical investigation, and other investigation like cardiac MRI, if required, with late gadolinium enhancement should be done. It's always better to do before a return to play. So Going again to the last one, basically Dr. Omlata Bhagat from AIMS Jodhpur, Dr. Gagan Kumar Banote from AIMS Saipur, and myself, we have designed a Google form and regarding basic applied clinical and interventional sports and exercise physiology, a survey among health professionals, as well as a survey on exercise, lifestyle, physiology, and medicine, so that we get a rough idea that where we are lacking and how we can to improve our skill as well as competency, our training on this field. So this is roughly we have a result of our survey. So here you can see that for basic and BACI-SEP, for basic and applied sports and exercise physiology, so 32.6% says that the present curriculum is ineffective, not sufficient. And curriculum to be updated, 44 to 2% yes. They say that yes, it has to be updated. It is not. In the same way, exercise, lifestyle, physiology, and medicine, if we see curricular training, insufficiency, do our curriculum for undergraduate as well as postgraduate, yes, they are not sufficient. Insufficient is there. 59.3% says that it is insufficient. And enhance proper, CME, symposium, workshop, online program or offline program or workshop, hands-on should be done in the field of exercise, lifestyle, physiology, and medicine. Around 70.4% of the people feel so. So what we can say from the survey is we know where we are lacking. We have our present curriculum doesn't incorporate all these principles, and many people, they want the curriculum to be updated, or they want a proper CME, symposium, workshop, hands-on training should be done regularly from time to time intervals. So, because the importance of the exercise, basic applied clinical and interventional exercise physiology and lifestyle medicine is so important in this current era where pandemic of COVID-19 not only is there, but pandemic of obesity is there, physical inactivity is there, and India, especially in India, where we have a high, prevalence of pre-diabetes, diabetes, pre-hypertension, and hypertension, and other non-communicable diseases, where they are basically the disease of lifestyle, where interventional, physiology, interventional exercise physiology has a great role to play with the coming of the exercise medicine, with the coming of the movement is medicine. So we, as a trained, medical exercise, interventional exercise physiologist and interventional lifestyle medicine physician or sports and exercise medicine specialist, we should be leading, this fight against this triple pandemic of COVID, as well as physical inactivity and obesity. Because for COVID also, it's been established now that the fitness prior to the COVID has a major determinant of mortality and morbidity of COVID, as well as the obesity and other non-communicable and lifestyle disease has a major impact on the mortality and morbidity of COVID. The real culprit is the non-communicable disease, obesity, low fitness, sedentary lifestyle. So this we have to focus, and we have to lead in this battle, and we have to win. So with this, I thank you very much for listening to my talk, and the most important what we should know is that regular physical activity, exercise, positive lifestyle, they causes positive physiological adaptation, and this will lead to the performance, fitness, and health. This is very important. So this is what we have to know. And I, Dr. Hanjabam Barun Sharma from Indian Society of Sports and Exercise Medicine, again would like to thank you all for listening to my talk, which is such a passion. And if there is any kind of question, so please go ahead and ask me. Thank you very much.